Thank you very much for allowing me to present this work on behalf of the Smiths cohort team. So we're going to be shifting gears completely today from adult medicine to neonatal medicine. There we go. And for those of you who may be less familiar with this area, I'm going to be discussing a new strategy for the prevention of mother-to-child transmission of HIV. Through the success of multiple national PMTCT programs, the risk of mother-to-child transmission in the developed world has dropped to less than 1%. Now, many of you have had the chance to be here in Canada for a few days, and I hope we've impressed you with our wealth of resources and infrastructure. But despite all of this, we haven't quite yet achieved what our colleagues in Cuba have, in that we haven't eliminated mother-to-child transmission of HIV. This is data from the Canadian Perinatal HIV Surveillance Database, which is a federally funded program that captures all women with HIV during pregnancy. And this is data from 1997 to 2014, which has accumulated over 3,200 mother-infant pairs. And we've seen here in Canada that when all interventions are in place and mothers receive more than 4 weeks of triple therapy, the risk of transmission has been 0.1%. But this increases to 3.1% when mothers have viral load of 40 to 1,000 copies per ml, 4.3% when mothers have received less than 4 weeks of combination therapy, and up to 15% when mothers have not had any therapy. And this group of infants is really primarily due to failed opportunities for prevention, and that these are usually late presenting mothers for whatever reason who've come to our attention, or they're due to treatment failure during pregnancy, whether due to maternal non-adherence or virological failure. So this represents a new challenge to us, these high-risk perinatally infected mothers. And so we need new strategies for targeting these high-risk HIV infants if we do want to eliminate perinatal transmission here. So I'm going to be talking to you about an old drug, which is very familiar to most of you, Raltegravir, but a new use in PMTCT. And though Raltegravir is a well-known drug and has been around for many years, it remains an FDA Category C due to limited data to support its use. However, despite this limited data, under selected circumstances, Raltegravir has been used late in pregnancy in women with very high viral loads to rapidly decrease the viral load, and there are a number of case series published on this. There is also evidence of transplacental transfer of Raltegravir. There's Impact 1026 and Impact 1097. However, despite this evidence, there's limited data on long-term outcomes among infants exposed to Ral in utero. And there are some potential toxicity concerns. There have been animal studies in rabbits that have shown an increase in supernumerary ribs in rabbits exposed to threefold the human dose. And there are some theoretical concerns. There's a potential increase in unconjugated bilirubin because both Raltegravir and bilirubin are albumin-bound and metabolized by the same enzyme, which could potentially increase the risk of kernicterus in the infant. And so the objectives of this study were very simple: to document clinical outcomes among infants exposed to Raltegravir in utero. So this is the maternal PMTCT component. And then to describe the use of Raltegravir in newborns for prophylaxis as the neonatal PMTCT component. This was a retrospective cohort study from the Centre Maternel Infantile sur le Sida in Montreal. And we included all infants born to mothers who were treated with Ral during pregnancy from 2010 to 2015. The results are different from that reported in the abstract because we updated the analysis to include infants until January of 2015. We looked at neonatal outcomes, and then to put this into context, we used a comparison group of infants exposed to regimens containing atazanavir-ritonavir at their base or lopinavir-ritonavir at their base, and infants were matched to the Ral-exposed infants by nearest date of birth. So Raltegravir in this cohort was given to mothers at a standard dose of 400 milligrams twice daily, in addition to their PI-based combination ART. Gestational age at the beginning of Ral treatment was pre-pregnancy for 5 and during pregnancy for 13 at a mean gestational age of 31.9 weeks. Indications for Ral in these pregnant women included drug resistance for 6, high maternal viral load near the end of pregnancy for 7, and late initiation of therapy in 7 at a mean gestational age of 30.4 weeks. Through the success of the Ral, maternal characteristic at the time of delivery included a CD4 count with a mean of 370 cells. Of the 18 women, 14 became undetectable at the time of delivery, 4 remained detectable, 3 at low level, and 1 remained at 55,000 copies. These are the characteristics of the infants of all 3 groups. These are very small numbers, but what is notable is that there were no significant differences in gestational age, APGAR scores, birth weight, length, and head circumference. We also looked at neonatal complications, and these were defined as any complications requiring pediatric or neonatal interventions, and these were fairly equally distributed across the 3 groups. We also looked at biochemical parameters, and interestingly here there was a difference in total bilirubin at birth, but it was not with the Raltegravir exposed infants, it was in the Atazanavir exposed group. And despite our small numbers, this was statistically significant. This remained so at 2 weeks of age and later normalized at a month of age. There were no difference in liver enzymes or hematological parameters between the 3 groups. We then looked at congenital anomalies and divided this into into mothers who were on ARVs at the time of conception and those who started later in pregnancy. In the Raltegravir group, there was 1 incidence of nystagmus with torticollis in a mother who was not on Ral at the time of conception. There were 3 cases in the lopinavir-ritonavir exposed group. And most interestingly, in the Atazanavir exposed group, there were 12 women who were on Atazanavir at the time of conception, and there were 4 incidences of congenital anomalies, all very significant in this group: hypospadias, panhypopituitarism, ocular cutaneous albinism, and an entire left leg hemangioma. And there was 1 case of bilateral sensorineural deafness in a mother who was not on Atazanavir at the time of conception. We looked at growth parameters to 6 months of age among these 3 groups of infants, and I'm not showing you the statistical test, but these were all non-significant, and there was an equal growth in weight, length, and head circumference between the 3 groups. We then looked at newborn drug levels, and this correlates with what was found in Impact 1097 to document transplacental washout, and that infants who had drug levels testable on the first day of life, we noted detectable levels until 30 hours of life, but afterwards when tested at day 4 and beyond, these were undetectable. And so to summarize the use of Raltegravir during pregnancy, there were no significant adverse events related to in utero Ral exposure to 6 months of follow-ups when compared to infants exposed to PI-based combination regimens of Kaletra or Atazanavir. And perhaps most importantly, there was no HIV transmission in this high-risk group of HIV-exposed infants. And though we don't have a control group, we do have historical data from the perinatal surveillance cohort, which had a 4.3% transmission in this high-risk group, or a similar cohort from ours and a number of other institutions where the risk was 8.8%. And so now moving on to the neonatal prophylaxis component of PMTCT, there are a number of national guidelines on this, and though we don't necessarily all agree on the number of drugs and the type of drugs to be used, there is general agreement that there needs to be a 6-week neonatal component to prevent peripartum transmission. And so a new challenge for us are perinatally infected women who become pregnant themselves, because these women generally have had a lifetime of ARV exposure and a history of non-adherence and difficulties with their regimens. So by the time they come to us pregnant, they are often multidrug-resistant, and this becomes a challenge for neonatal prophylaxis as they're resistant to all drugs approved for use in neonates, zidovudine, lamivudine, and nevirapine. And so when Merck developed Raltegravir granules as a suspension, this became a very attractive option for the prophylaxis of these newborns of drug-resistant mothers. And there is currently a clinical trial, Impact 1110, for infants under 4 weeks of age. Knowing this trial was underway, when faced with this situation in our cohort, we elected to use Raltegravir for the PMTCT of 2 infants, thanks to Merck and Health Canada Special Access. I'm going to describe to you the use of Ral in these newborns. And so the first newborn was born again to a mother with perinatally HIV infection herself, multi-drug resistant, and on a regimen containing dolutegravir, etraverin, darunavir, ritonavir, and Truvada. Despite all of this, due to non-adherence, she remained detectable in her 3rd trimester. And so when this child was born, we elected to initiate a triple combination regimen of AZT, 3TC, and Raltegravir at 1.5 milligrams per kilo twice daily for 6 weeks. We did weekly therapeutic drug level monitoring, and this child was able to maintain this dose of 1.5 milligrams per kilo twice daily with trough levels that were well within the target for treatment and prophylaxis. We also did biochemical monitoring, and there were no adverse events related to the triple combination regimen in this infant. Newborn 2 was also a child of a perinatally infected mother herself. This time she refused all ARV therapy during pregnancy. Viral load at the start of pregnancy was 83,000 copies, and again, genotyping revealed drug resistance to all NRTIs and NNRTIs. And so we weren't able to treat this mother, but when the infant was born, we elected to put this child on a quadruple drug regimen of AZT, 3TC, lopinavir, ritonavir, and Raltegravir started at 1.5 milligrams per kilo twice daily. In this infant, we required frequent drug adjustment. By 3 weeks of age, we had to increase to 3 milligrams per kilo twice daily. And by 4 weeks of age, this was increased to 6 milligrams per kilo twice daily to maintain the necessary trough. Again, in this infant, Raltegravir was well tolerated without any adverse side effects. So in general, our 2 Raltegravir babies have shown us that there is tremendous variability in drug levels requiring dose adjustment, that there were no adverse effects through 6 weeks of therapy in a combination regimen. Most importantly, both infants were confirmed HIV uninfected through our standard testing, and Raltegravir was very well tolerated with minimal preparation challenges, and you have here the instructions for the formulation. So in summary, Raltegravir may well have a role to play in the prevention of mother-to-child transmission in these specific high-risk situations. Notably, there were no cases of transmission among high-risk RAL-exposed newborns. There were no significant adverse events from in utero RAL exposure until 6 months of follow-up. And these Raltegravir granules for suspension at doses at 1.3 to 6 milligrams per kilo were well tolerated without any adverse side effects. There are further dosing recommendations. Impact 1110 has continued on, has done some nice modeling, and these are found in the following posters. So there are some dose-specific recommendations to 6 weeks of age. An important caveat, though, is that if this regimen is to be used until further PK and toxicity data is available, there needs to be careful monitoring during pregnancy, there needs to be therapeutic drug monitoring of the newborn, and long-term follow-up necessary to ensure that there are no adverse side effects. To conclude, I'd like to thank the entire Smiths cohort team and to acknowledge our funders, des Fonds de Recherche en Santé Québec, and especially le Réseau SIDA Maladies Infectieuses, that's been inherent in providing infrastructure support to our cohort. And I'd really like to acknowledge the folks at Merck, Dr. Hetty Tapler and Jeff Fortin, who were instrumental in helping us get these Raltegravir granules and get through Health Canada in order to get these in time for delivery. And also to Dr. Nancy Sheehan at the McGill Center for Therapeutic Drug Monitoring, who provided the rapid turnaround for our Raltegravir results. And with that, I conclude. Thank you.
Thank you very much.